Now we're going to be talking about pediatric spinal cord injuries. This starts on page 751 in your PEDS book, and it's very condensed, so it's a very good guideline even for the adult with a spinal cord injury. Spinal cord injuries in children are usually caused by motor vehicle accidents, falls, sports injuries, tumors, congenital abnormalities, gunshot or knife wounds, or attempted suicide. In the infant, a common cause is intentional aggressive shaking by an older person, especially their parents, unfortunately. I brought up this slide because this has the effects of spinal cord injury on the specific level of the spinal cord, such as the cervical will have paralysis of the muscles used for breathing and all of the arm and leg muscles, usually C1 to C5, usually fatal, especially the C1 to C2. C5 to C6, it kind of narrows them down a little bit. The legs are paralyzed slightly, slight ability to flex the arms. C8 to T1, the legs and trunk are paralyzed, the eyelids will droop, the loss of sweating on the forehead, which is also called the Homer syndrome. Arms relatively normal, hands are paralyzed. Kind of synopses it into the different areas and what the effects are going to be below the area of injury. So I do not want you to memorize this. I just want you to have an overall concept of the effects of the different areas, knowing that the new term for if you have an injury that's high, C1 to C5, that used to be called quadriplegia, now it's called tetraplegia. If it's lower and it causes paraplegia, which would be half the body. And that's that paralysis that's usually from the middle of the trunk down. So when we talk about the incidence of spinal cord injuries, they're less common in children than in adults. With spinal cord injuries, they occur in about 1 to 3% of children who sustain these injuries. Most of the injuries that occur in children occur in that cervical spine between the occiput and C6. Young children are more susceptible to upper spinal cord injury because of the head size is larger in relation to their body size. And as the child grows older, the likelihood of the spinal cord injury moves, of course, distally. 75% of children who sustain spinal cord injuries from motor vehicle accidents were not wearing seat belts at the time. Now we're going to talk a little bit about the signs and symptoms of spinal cord injury, and those signs and symptoms include loss of some or all of the movement or sensation below the level of injury, such as respiratory depression or apnea, hypotension, bradycardia, hypothermia, and neck pain as well. They vary with the level of injury as to whether the spinal cord injury is complete or incomplete. And if it's complete, the cord is completely severed and there's no spinal intervention is present below that injury. For example, with a complete injury at the C2 level, the child is apneic and requires ventilator support. With an incomplete, the cord has some function remaining below that level of injury. Basically, on the diagnostic eval, the nurse takes the history of the injury, performs a complete neurological exam. The extent is usually determined by an MRI. And it's important to remember that the extent of the motor or sensory deficit may resolve somewhat as the spinal shock resolves, and that's usually within the first 24 hours. Now we're going to talk a little bit about the therapeutic management of the patient that has a spinal cord injury. Treatment includes immobilization and steroid therapy. Those are the two main things. You can maintain immobilization by traction, and those are the tongs that can be used. As you can see, the tongs are connected to the scalp of the head, and they have traction, usually around 40 pounds here for an adult. It'd be less, and it would be ordered by the physician. And also halo traction braces. The biggest thing with traction and stabilization is that you make sure that you do not pull on any of the traction when you want to turn the patient, when you want to move the patient. Make sure that you do not pull or use the halo as a brace to reposition patients or to get them in a different position, or in helping them with repositioning. So also you need to make sure that you look at the insertion sites of the halo and of the tongs to make sure that it's clean, free of debris. Usually they have some kind of protocol to clean the site with normal saline and maybe applying some Neosporin ointment to the site as well. So in our nursing care, we want to make sure that